Thank you very much. It's a real pleasure to be here today. And for the sake of all of your ears, I will not subject you to my Canadian-Danish accent on Norwegian, because it would not be pretty. But I look forward to having conversations with you over the course of the day. I was asked to talk a little bit about the journey that we're on in Canada, a journey that I think, as I've talked with many people around the world, I think all of us have many of the same destinations in mind, but the paths that we've taken to get there vary, and so we're at different points along that journey and have some lessons learned for each other as a result, I think. Just in terms of setting the context, Canada, like Norway, is a very large country geographically, with maybe a smaller population spread out around that large geography. Our health system is organized within a set of national principles set by the Canada Health Act, but the actual delivery of health services is the responsibility of the 13 provincial and territorial governments. So we do have variation within the country as well as with other countries. There are about 1.5 million people who work in health and social services, broadly defined, and we spend about $200 billion a year. It's gotten easier now that the Canadian and US dollars are approximately equivalent. I no longer have to do a conversion for those who are more used to US dollars. And the split for us is about 70% public funding versus 30% private funding, with most of the private funding going to things like dental care, some pharmaceuticals, and other types of services like massage therapy and so on. Where we're at in terms of health systems is we've just finished a whole round of provincial territorial government elections, and there were a number of common themes that came out of those elections. A desire to focus very much on either patient or person, we have the same debate, centered healthcare. Collaborative teams, so looking at how can people work together more effectively, particularly as individuals who have chronic conditions are touching many, many places within the health system and their care needs to be brought together. Improving access to care and efficiency of care, really focusing on both the quality and the patient experience, especially for those with chronic diseases who may have long-term experiences with the health system and experiences with many different parts of the system. And last but certainly not least, support for seniors, those people who are an increasing proportion of our own population as well, those over 65, who again may have more interactions with the health system, but also wish to continue to live active and healthy lives. And within all of these categories and others, there's a common sense that IT can be an enabler and a catalyst for change. So it's certainly not the only thing that you need. A computer sitting on a desk gathering dust does nobody any good at all, but it can be one of the ways that we can start to look at transformation. It was one of the motivators behind creating the organization that I work for, Canada Health Infoway. We're a national organization, but we are owned by and accountable to all of the governments across the country. So because we have this division of powers in terms of healthcare, that's important that we can bring those perspectives together. We work very closely with health ministries and our partners, engage clinicians, and have a series of core programs around things that I'm sure would be no surprise here either, things like privacy, security, standards, change management, and a common architecture. One of the things that may be a little bit different, so I'll take one slide to explain it, is that we work primarily as a strategic investor, which means that we put about 75% of the money on the table in terms of investments in health IT, with the other 25% coming from the provinces and territories or local health organizations. So it's a shared partnership in that way. All of those programs fit within a series of national initiatives, and we have an approach where 20% of the money flows straight away as soon as we've agreed that the project will go ahead. Another 30% flows up to the time when the system goes live, so on implementation. And the last 50% is based on adoption and use. So as usage increases, the rest of the investment flows. Why is that important for us? It's important because fundamentally we do see this infrastructure as an enabler of a high-quality, sustainable health system that allows us to get the right information at the right time, with respect for privacy being fundamental. And as I've talked with people in other countries, we may use slightly different words, but many of the perspectives, I think, here are common and shared. We've focused initially primarily on the role of the electronic health record, providing each individual Canadian with a private lifetime record that includes information from all of the care providers that they see. So, for example, all medications, regardless of who they were prescribed by, or access to all diagnostic imaging, regardless of who ordered it. Designed really to facilitate the sharing of data among authorized care providers and individual Canadians. Just a couple of other things that I'll point out here. We can't do this without others. This is all about holding hands with our partners, whether it's clinicians, whether it's also the private sector, who are important partners in delivering some of these solutions. But we have a series of programs in place to manage the risk and look at trying to accelerate the benefits as well. So what does this actually mean? This is a sort of example of how the resources that we've been allocated by the federal government, because we are funded by the feds, have been allocated over the last several years. The core set of components around infrastructure, so basically making sure all of the pieces are going to fit together, having that common vision across the jurisdictions. Then a set of core components of the electronic health record, so registries for clients so we know who the right people are, and providers so that we can make sure that the right clinicians, for example, have access to information. Medications, laboratory systems, diagnostic imaging, and what we call the interoperable electronic health record, which includes things like hospital discharge summaries, other core pieces of communication among care providers. Taking advantage of that core set of services, then we have a series of applications. The electronic medical record in a physician's office, for example, being a point of care system that would allow you to access that common information. We're now starting to move into some of the same things that you spoke about in terms of consumer health solutions. So here we've added a third word. Now we're calling them consumers, patients, people, and consumers. Public health surveillance, which has been very important to us in terms of not just outbreak management, but also the basics about immunizations and management of public health services. I'll speak a bit more about telehealth, because that's something I think we share an interest in, given the natures of our countries and geography. Innovation and adoption, looking ahead and being able to try and do some different things that will allow us to test new ideas, new solutions that may be applicable more broadly. And last but not least, patient access to quality of care, focusing on the challenges of access and quality, and how can we use IT solutions to achieve benefits in those areas. Our current focus, completing the electronic health record, work that we started at the beginning, point of care systems like electronic medical records, making the various pieces fit together so that pharmacies and hospitals and long-term care and doctors' offices can all work together around that individual. The consumer health solutions, new solutions around clinical innovation, so trying to look at things like infection management or medication safety, and how do we support those needs. And last but certainly not least for us, public education. We've done some work in terms of looking at where are Canadians at in understanding what we're trying to do and where we're trying to go and their role in that. And one of the things that came through was that we needed to do more work actually reaching out to Canadians. So among other things, we've actually been running a series of public education campaigns, including this announcement, just to give you a flavor. Oh, and it's not going to work. We did test this. But the miracles of video are not with us today. You can see it on our website, though. So we've been running a series of these campaigns across the country, trying to increase awareness among Canadians. We have this interesting dichotomy that both there's relatively little awareness, but when we actually ask Canadians, most of them assume that much of this is already in place and operational. So we need to help people understand where we are on the journey and where we're going and what they can do to help us get there. Equally, it's important to us to work with the clinical community. Ultimately, our clinicians, whether they're doctors or nurses or pharmacists or others, are the ones who get up every morning to take care of patients and improve health across the country. And so we have a new clinical engagement strategy that includes not only linking with leaders, which is obviously very important, but also reaching out to direct care providers and the next generation of clinicians, recognizing that it's very important that if health IT is to become the clinical equivalent of the new stethoscope for taking care of patients, something that is just part of the ways that you practice, we need to make sure that that's something that you're learning as you're training, so that when you graduate, you're ready to practice in a technology-enabled environment. Now, this is not about Computers 101. Nobody going through school these days needs those kinds of things. They've grown up in this kind of world. But it is about how do you effectively use a medication history that's online, for example, to do medication reconciliation when a patient comes into hospital. Or how do you really effectively use telehealth in a mental health consultation? Those kinds of things are important in terms of training the future generation of health professionals. So where are we at? In terms of Canadians, we have strong support among the public, with about 9 in 10 saying that they support the development of electronic health record, and a number that was a bit higher, I think, than any of us necessarily expected when we ran the survey, with 97% saying it was somewhat or very important that their health records be kept electronically so that they could easily be transferred around the health system, and 9 in 10 interested in having access to their own personal health records. And I'll talk a little bit more about some of the things we're doing in that regard. When you look across the health system, as I'm sure it is here in Norway, it is a complicated and broad mosaic in Canada, with many different points of care, all of whom need to talk to each other at different points. And as you look at the developments in use of health IT, it varies across these sectors and across the country. So if we think, for instance, about first you need to have things basically available, but availability is not where you want to stop. You need use, and then you need to target those benefits for individuals and for clinicians. On the availability side, areas like client and provider demographics, the basics are pretty much there across the country. Similarly with diagnostic imaging, having them digital and in shared repositories, broadly available. Not as high in terms of dispensed drugs. About 53% of Canadians have an electronic drug information system history, which means all drugs and all people, not just the medications that might be prescribed by one doctor in their office or in a hospital, but bringing that together. 66% for lab results and 74% for a variety of clinical reports and immunizations. So we still have a ways to go, but this is one of the journeys that we're on. It's a journey that we began back in 2001, and shortly after that time as a country we set a goal of having all of that information, all of those components available for 50% of the population by 2010 and 100% of the population by 2016. We almost made it, but we were at 49% in December of 2010. We crossed the 50% line, I think 50.1% in April of 2011, so we missed it by a couple of months. But we are now working towards our goal in 2016 to have it available for all of the population. As I said, though, availability is not actually the most important thing. What we really want to strive towards is benefits. Benefits for individuals, benefits for clinicians, benefits for the health system. And so one of the things that we're focusing on is really trying to understand where we're at in terms of benefits, evaluating the benefits, where are the strong points, where are the weak points, what can we learn from early adopters to try and accelerate up that curve. And we have a framework that we're using to try and understand on the very far side benefits in terms of quality, access, and productivity within the health system. In terms of actual use of the systems, user satisfaction with those systems, and then at the base level, some of the functional aspects in terms of things like the quality of the systems themselves or the information, those kinds of things. So to give you a sense, 3 of the big studies that we've completed in the last couple of years. On diagnostic imaging, one of the areas that's gone most quickly, we're currently seeing benefits in the health system valued at over $600 million a year. Primarily that's coming from improvements in productivity, with radiologist and radiology technician productivity up about 25% after the introduction of systems with shareable diagnostic imaging. It's interesting, though, that the balance changes as you look at different types of systems. So with drug information systems, we're currently seeing benefits of just over $400 million across the country. The majority of those benefits are actually coming in terms of quality, better drug management, those kinds of benefits. So productivity is a lower component of that share. And then in terms of telehealth, sometimes called telemedicine, different words used in different parts of the world, the real benefits that we're seeing at this point come in terms of access, with quality benefits coming along as well. So currently, our big focus has been on making sure that all of our remote communities have had access to telehealth services and that they're connected up as well. And last year, we saw 47 million fewer kilometers worth of travel for patients who would otherwise have had to get in a car or get on a plane to receive care. If I delve into that a little bit more in detail, because I think unpeeling the onion actually helps, just got a couple of examples. The first one in terms of medications, which, as I said, the majority of our benefits are coming from things like reductions in adverse drug events, reduced prescription abuse, improved compliance with a medication regimen, mostly because pharmacists are able to work more effectively with their patients to help understand, where have patients not been refilling medications, for example, where are they having problems in terms of side effects or other issues, that they can then work with patients in terms of improving access to that care. We're starting to see other types of benefits as well. So I think, as in Norway, Canada has a national patient safety campaign. And one of the components of that campaign is around medication reconciliation. So making sure at transition points in care, we get medications right, and that we know what patients are on coming in and what they should be on as they move on to the next point in care. This was a study that we recently completed, a trial that looked at the use of a full medication history in that context. So this is a surgical pre-admission clinic that was already doing a lot of work in terms of medication reconciliation. And that's important because the starting point here already reflects significant progress for the clinic. Nevertheless, over a quarter of patients, when drug information systems were not used, had at least one discrepancy identified through medication reconciliation, and 7% had at least one clinically significant discrepancy, something that could have impacted their health, for example, or their care. Those rates dropped significantly when clinicians had access to a patient's complete medication profile. So one of the things that we're doing now is we're looking at how can we work with clinicians across the country to more effectively use these kinds of tools and resources for medication reconciliation, not just in surgery, but also in long-term care, in home care, in other settings as well. And we have room to believe that we have opportunities for further progress. So this is a survey that we did last year with pharmacists across the country. And we saw that in jurisdictions that had more mature drug information systems, that had had patients' complete medication profiles since the mid-1990s, they were reporting productivity gains of about 13%. Whereas jurisdictions that had just introduced these kinds of systems were reporting productivity gains in about the 3% range. So what our challenge is how do you accelerate people up that curve? How do you help to get these systems in place and in use effectively more quickly so that we can get these gains for patients and for providers in a more timely way? Which brings me to one of our new campaigns. We have a slightly cheeky slogan on this one. I'm not sure all of our public health colleagues would agree with us on this. But one of the things that we're doing is we're actually challenging healthcare providers across the country to work with us in 4 areas, one of which is medication reconciliation, to use health IT to make progress. And the way this works is we're actually looking at providing incentives to those who are early adopters and those who are trailblazers, so who have the most growth in users or the highest level of use throughout the challenge. And our real goal here is not so much to provide these incentives, but actually to identify successful strategies. Successful strategies not just for introducing health IT, but for change management, for putting it into practice, for making sure that it's providing value for patients and for their clinicians. Speaking of which, my second example, telehealth. This is obviously when the individual and their care provider aren't in the same place. And this is something that is fairly broadly used now in Canada, but we continue to see significant growth. So over the last 5 years, we've had growth in use of about 35% per year, and we expect that to continue over the next few years. The interesting thing is, for us, it's actually becoming rather hard to count this number now, because it's just the way we do things here, and so it's no longer special. And so it's always easier to count things that are special and in a separate program than something that is just part of normal care delivery. We think that's a success story anyway. So as I'm sure you have examples here, this was sort of the traditional way, I guess, where if somebody with congestive heart failure would be monitored intensely when they had an episode that required them to be in hospital, but in between those periods when they were out in the community living their normal life, they might not have that kind of support. Whereas we're now moving to situations with home telehealth where an individual in their home can have monitoring available to them. There can be opportunities for both themselves to learn more about their condition and how to reflect the changes that they're making in their lives, but also for early intervention by a clinical team and different ways of interacting with that clinical team. So this is an example of a gentleman, for instance, who is in one of the remote parts of the country, who's able to connect in both automatically with vital signs and so on being sent directly to their care team, but also by video for consultations and other issues. I mentioned already the avoided kilometers. We're currently seeing about 70 million in avoided personal travel costs, so things that people would pay out of their own pockets for a bus ticket or gas or those kinds of things. We're also starting to see benefits for the health system, primarily in terms of home monitoring and reductions in things like readmissions, emergency visits, and so on, from more effective chronic disease management. And I'm probably tempting fate here because I do have a second video. We'll see if it works or not. But the numbers are one thing. I think this is an area where the stories actually are the important thing. And so this is a story of a family who lives in one of the northern parts of Canada, who have the cutest little boy. He's 2. His name's Nicky. And he has a very bad burn on his hand, to the point where he couldn't actually open his hand. And they live about a 9-hour drive from the specialist hospital where he had surgery on the hand and then needed follow-up. And so, we'll see if we can get... No luck. Okay. What their story is, though, is about, the value of avoiding 9 hours with a 2-year-old in the back of the car. And for anyone here spent 9 hours in the back of a car with a 2-year-old, even 5 hours maybe, there's a few. Believe me, that was something that they valued strongly. But they valued it even more strongly because by going to their local health center and using telehealth, they were able to get the best quality care right close to home. And so I think these kinds of things are the things that really make a difference. Whether it's that kind of a story or whether it's a story that I heard just a couple of days ago about a family, a husband and a wife. The husband has dementia and is living in a long-term care home, and he gets confused. But his wife can no longer, particularly in the winter, travel to see him at night because she can't drive at night. And so the care team has used very simple video technology to connect the two of them, so that when he's agitated, she can talk to him and calm him down, and he needs much less medication as a result. And obviously that makes his family happy as well, because they're able to connect with him and know that he's fine and okay. So I think it is those kinds of stories as much as the sort of hard numbers that we're trying to achieve as well. And in terms of what's happening sort of now and next, just to give you a couple of examples of some of the kinds of things that we're looking at. Projects on the value of clinical mobility, so taking whether it's iPads or other types of tablets into clinical settings and the difference that that can make, whether it's in home care, in hospitals, and elsewhere. New approaches to infection control in hospital, where you actually have RFID tags clipped to both machines and to people, so that you can do more intensive surveillance when you've got an outbreak that you're trying to manage and really be able to aggressively target those particular infections in hospital. Helping patients to navigate the diagnostic process. So this is an example that comes, our National Cancer Society recently did work with their community and found that one of the most difficult parts of the treatment journey for patients was actually that process of getting to the diagnosis. Because there's often multiple things that need to happen. You need diagnostic imaging, you might need various types of interventions, and it's an unknown process for most people embarking on that journey. It's not something that they've been through before or their families have been through before. So they're introducing a new process to help patients navigate that process, communicate electronically with their care team, and hopefully get them through that process in a more peaceful frame of mind, even if that journey is not easy for anyone. We're also starting to see mobile health and apps come in. This is an example in terms of diabetes. It's had a clinical trial done on it recently where the kids who were using it got points on iTunes if they were effectively managing their health condition, and some quite positive results actually from using it. If you're interested, it's actually free on the iTunes website. You can download the app and have a look at it yourself. But some creative ways that people are now looking at how to help all of us manage our own health and improve that over time. And two more, just to give you a last couple. Some new ways of providing pharmacy services. So this is telepharmacy. You can see the gentleman here is connected up by video and phone with a pharmacist and gets automatic dispensing of the medication from this machine. So it's being used in remote communities that may not have pharmacist services on site, so that people don't have to travel to get medications. It's also being used in some cases for after-hours care, where the regular pharmacy may be closed at that period, but you're able to extend into either late night or 24/7 access to pharmacy services through this kind of technology. And my last example, mental health engagement. Some compelling evidence, I think, from a variety of work that's been done internationally in terms of now using some of these new types of technologies and tools for helping people to manage everything from depression to more other types of mental illness, and being able to build communities and support into that as well. So it's both formal care provision and also informal networks and support. So there's been progress made, I think, in a bunch of places, but there's lots more to do. And this quote, I think, is one of the most compelling for me. It actually comes from south of the border, but some of you might know Don Berwick, who used to be at the Institute for Healthcare Improvement, who talked about that challenge, really, of maybe it's not Nikki in the back of his car, but somebody in the back of the car saying, why aren't we there yet? Why aren't we there yet for everybody? And the reason is because it's hard. This is not just about new hardware. It's about new skills, new attitudes, new assumptions. It's really a new culture. And you don't get there in one step. But that said, we have to get there. And so one of the other things that we've been focusing on a lot is change management. And looking at introducing, we have a group from across the country who've brought together evidence in terms of what's effective in promoting and accelerating change, building on both information from the health sector and also from other sectors, and what can we do to actually push this forward more quickly. Because, stealing a quote from yet another country, Sir Winston Churchill, it's not the end, it's not even the beginning of the end, but it is perhaps the end of the beginning. Thank you very much.